Excellent. Thank you, Merv. I would like to invite both speakers to come now to the scene. Let's see. There we go. We would be very happy now to, if there are any questions from the audience. I do want to say to the people following us online that if you have any questions, please write them in the chat and we'll pass them on. And we will also make sure that any questions that are asked here in the audience, we will repeat the question so you can follow what we're talking about. So any takers? Any first mover?
Break the ice.
Yes. So Victor.
Okay. Thank you very much for the two talks. I'm going to be closer to the microphone. They've been very, very interesting and very well exposed. My question is, well, in our project, we take health literacy very important. And my question is for both of you, to what extent do you think that poor health literacy it might be a barrier for engaging in either a value-based therapy or an exercise program with the perspective you have presented?
Yeah, I really think health literacy is very important to be mindful about, because the patients that we have been treating in the trials that I've shown you are very privileged and with very high health literacy, and this is definitely not for everyone. But I think what's key is that what you also mentioned, to give them some new bodily experiences, because that can heavily override these misinterpretations. So you can do that even without high health literacy, I think, but that requires some other skills.
Yeah, I agree. I think it's a really good question, because we know unfortunately there are social kind of determinants of all healthcare outcomes, but pain, within that as well. And yeah, one of the challenges for kind of more top-down kind of approaches like pain reprocessing therapy, for example, that trial that showed a really promising effect for low back pain, but most of their people were kind of university educated, etc. So you have to look at those cohorts. I think you're right. I think that's where experiential learning probably overcomes some of that. I think to be honest, irrespective of health literacy, I think we have to think about things like pain education. If someone's had an experience for 30 years that every time they put their shoes on it, it hurts their back. Like simply telling them didactically, well, don't worry about it, your discs are fine, it's probably not going to override, like it's not going to carry enough weight or strength within the system. And I don't think anyone who's researching in that kind of space suspects that's the case, but it's sometimes how I think it gets applied in clinic.
Yeah.
And I think it's the power is in more experiential, and that's in part what I think the value-based stuff is doing that too. People it's just another form of doing that. So I think for clinicians, it's a bad experience. It's about experiencing, and even beyond that, if we can demonstrate in some way by listening to the person and talking to the person, rather than talking at them about pain, but listening to their experience of modifiability. Are there experiences in times where they have demonstrated modifiability? Like, my pain was better when I was off work on holidays, or I went to my kid's wedding and my back just didn't hurt at all that day, or my pain was terrible when I had something that was non-tissue based. Can we reflect on things like that and use those experiences to explore the idea that pain's about more than just tissue damage, rather than giving a kind of neurobiology lesson? And I think maybe, if it's grounded in the person's story and the person's experiences, then I think we overcome some of the barriers of health literacy. We don't overcome all the barriers of kind of social determinants of pain, but I think it's a start.
Yeah, I guess it demonstrates that it is not just about treating patients and knowledge, but also the experience they have, and also the competencies, no?
Yeah, of course. Yeah, of course.
Okay, thank you.
Very good. We have one question here from the online audience, and it sounds: how should healthcare education's physiochiropractic medicine change in the future in order to reflect this knowledge? Is it simply a minor change in the curriculum and clinical training, or do you think it's more fundamental changes that are required? That's
All
a
right,
tough
I'll-
one.
yeah.
That's a tough one.
That's yeah. Look, as someone who's involved in health education, I might well just lose my job on this one. Look, I actually think it's really important. Because it takes time. Like, Tony's studies, they're new, right? The study that I presented was published only a year ago, right? It takes time for these things to be implemented. But I also think the structure of how a lot of universities work now is different. When I went to university, it was like, this is the physio school, and you didn't learn stuff from outside that discipline, and your scope of practice. And you mentioned as a barrier earlier, like this, and I think Stefan said, well, like, stepping over boundaries, like we had this defined scope of practice. And I'm not saying that, of course, we kind of say, to hell with my scope of practice, I'm going to do what I like. But I think clinical practice has evolved to be more transdisciplinary, I think.
Yeah.
And I think our education needs to reflect that. So less education, not so much in silos, and preparing people for the realities of dealing with patients like this, which comes with multidisciplinary and transdisciplinary care. Yeah.
Yeah, I agree. I think we really need to be on the top of the curriculums on both on physios, chiropractors, and medical doctors, and then we need to do some postgrad training in a multidisciplinary way.
Yeah. But also reflecting, it's not easy.
Yeah.
It'd be very hard to deal with, some of the patients that I deal with, for example. I couldn't have done that 20 years ago.
No, definitely
Like-
not. Me neither.
Yeah.
No.
Diane?
It's a follow-up question.
Yeah.
Thank you for your talk. So Tony mentioned that perhaps it would be 20, it was 20 hours of training for the physios involved, but they didn't do the first 3 sessions.
Yeah.
Do you think, could you put a guess on how much extra training they might need to do those first, or is it so clinician specific?
Yeah.
Do you want to repeat the question, or do you want me?
Yeah, the question was this value-based CBT that I presented, and I said that we did 20 hours of training, and the psychologist did the first 3 sessions where they discovered and explored those life values. So the question is, how much extra training would it take for instance, physios to do that, right? I think because they were so experienced, the physios that we used here in this SCET study, and they had like 25 years of experience with rehabilitation of spinal cord injury and pain and etc. They could have done it equally well as the physio. So I think it really comes down to some very soft skills about active listening, asking the right questions, sitting on your hands and just listening. I could almost put up a list of questions that you could ask, and then you would have this meaningful conversation. So I don't think it would require almost any extra training. I actually regret that we had the psychologist do it. The reason we did it was that the psychologist was doing this pain science education, and we had an idea that she would be more of an, more skilled to do that, but really she wasn't.
Very good.
Okay, I have another question from the audience here. I think it is for Murph. Where do you draw the line between placebo and fooling your patient? Take, for example, doing manual therapy on a patient's neck, and at the same time, your knuckles crack, and the patient reacts by a relieving sigh and verbally says that was perfect. Would you tell them that it was your own knuckles, or not the neck, and not the neck?
I don't know. Like I always learned playing. I grew up playing rugby, and I always learned that the rugby ball is unpredictable in its bounce. If you get a lucky bounce and it bounces in your hands, don't ask why, just run, right? And I think perhaps clinical practice is the same. Look, it's a really, really important question, and I think it speaks to professional identity. I don't think anyone wants to see themselves as a kind of purveyor of placebo, right? But at the same time, to ignore the expectancy effect of treatment, I think would be extraordinarily naive and not doing right by your patient. So consider a patient who comes to see you who has a long history of pain, and they say, the only thing that has helped me even a little bit, that gives me a little bit of relief, let's just say, is someone cracks my back, right? And you know, of course, maybe we've been listening a lot lately and we're taught that, like, you know, that's a passive treatment and I can't do that. And I think to myself, wow, that person has given me a very powerful tool to enhance our relationship, have some buy-in, get us on the same page,
Exactly.
and actually positively influence their pain in the short term. And can I leverage that experience? Going, look, I've not actually changed a lot here, but your pain is different. So maybe it's not just about, you know, there's a lot of ways you can use that. So I think what we have to be is we have to be academically honest. You know, I don't think so you don't sell people false hopes and you don't, you know, say this treatment is really good and evidence-based or whatever else, but they have an implicit and often explicit expectation. And I don't think there's anything wrong with leveraging and enhancing that. Like to give an example, when I'm teaching my students and we have a lecture on exactly this topic, right? And I talk about how, well, you know, maybe if I'm presentable, they might think I'm more, you know, professional, right? If I'm dressed, and maybe if the clinic is clean and tidy, they might think the same. And maybe if, you know, I speak with clarity and kindness, they might, you know, get on the same side as me. And maybe if I ask them about their preferences and try and respect those, they might be the same. And I thought to myself, well, why would I be like not courteous and not kind and not open to my patient? Like, I'm not just doing that to enhance like the therapeutic effect. I'm doing that because that's kind of how you should be, right? And so I think it all entwines, you know, and so that's, you know, the flip side of that is the patient goes, well, I had 58 sessions of acupuncture and it didn't work for me. And you kind of go, yeah, that's probably why we should try something different, right? But if they said, I've had this and this has helped me in the past, then you go, yeah, that's okay. So I hope that answers the question. I think to not use the expectation kind of influence would be really undermining and in some ways a denial of care. Yeah.
There's actually two quite nice studies out there. There's a consensus paper from all the placebo experts in the world. They recommend to use placebo openly.
Yeah.
That's one. And then there's a very big meta-analysis. I think it's 15 studies of using open placebo, not deceiving people, but telling them this is a powerful effect. The brain does this and that, as I told you. And this is actually showing effect sizes on the positive side overall. So placebo works even if we don't deceive people.
Can I counter that with it by flipping, because we've got a paper that's just about to get published. So I can tell you just about enough of it for it to be interesting right now. But we did a study because we talk about so often we get told, I'm sure you've all heard the idea that your words affect people's pain. Yeah. And people's understanding effects of their diagnosis affects their pain. I would argue that's never been studied in a patient cohort in an appropriate way. All right. It comes from, we zap people with lasers and, you know, you got to think about all the things that are bound up within that. So we decided to get a group of patients with a chronic condition on their very first consult. So they were as naive as you can possibly get people in the world where everyone has an iPhone or whatever, right? But they hadn't received a lot of diagnostic information in the past. And we had ethics that took 2 years to get to deceive these patients. It was all approved and all appropriate, but we told them, we asked them, could you be part of an experiment while you're here in the clinic, research project? We just want to test some of our equipment and some of the reliability of some of the clinical tests that we're going to use on you. That set us up for our pre and post measures. What they didn't know is they were randomized into two groups, one of which got the standard and very traditional model of giving the person diagnostic information. So they were told, in this case, it's very often that condition, they're told that they're degenerative and they're showing their scans that show degenerative changes and all that kind of stuff. And in the other group, we had to argue hard with the ethics board to say, we think that the traditional model may be harmful and it sets them up with a negative expectation, right? So we just want to tell them something that's, you know, a bit softer. So we told them that the tissues that are sensitive right now, not broken, not damaged, not degenerative, the tissues that are sensitive are actually a victim of your system not being strong enough, right? So like the way you go for a run, if you haven't been running for a while, you overload your tissues, you go to the gym, you do too much, that's what's happening X tissue because but we can change that. We can recover that. Sure, we can retrain you to get strong. Like that's really easy. immediate reduction in pain on testing, immediate, and a clinically worthwhile reduction. So if this had been like a 12-week RCT, you were saying, well, we just, done groundbreaking work, right?
Yeah.
But we just did it in the context of like immediacy to see, is this a phenomenon that exists? But that speaks to the power of your expectations. All right. And so I think to deny care or to not leverage the kind of expectation, I think the problem is placebos become a kind of dirty word, kind of vilified. So I dare say what they controlled for in that study is the patient's expectations that they get better.
Expectancy effects.
Yeah, that's right. So I think it cuts both ways. So we have to actually be mindful of the expectations that we set for people. But we also can't be responsible for the expectations they already have. We just have to treat the person who's in front of us.
Thank you. I have another question. We might go for 2 more or so. I think this one is for Tony. Working with a patient with the comorbidity of chronic pain and PTSD, for the translator is post-traumatic stress disorder, I find that you or we can now explain most of the reasoning between the 2 coexisting conditions, and how both can be approached with similar approaches, as well as other persons with chronic pain. Do you have any reflections on treating chronic pain and mental health condition at the same time?
Yeah, that's a huge question.
Yeah.
I would say that we have tried a lot with the post-traumatic pain whiplash patients. We have tried to treat their PTSD first with CBT and with some more bodily oriented PTSD treatment, and that didn't work better than exercise, actually. And then we have tried to treat it with something called prolonged exposure, and that didn't work better either. But now we are trying in an emergency department study to treat it very early on those who are high stress responders after the injury. And Michelle Sterling from Australia has shown some promising results in a small trial there, trying to prevent it to develop. So I think when the 2 conditions, they are really well developed, then they somehow mutually maintenance each other. So it's very difficult to treat when it's chronic, and there's no one size fits all what to treat first. I actually think it comes down to the individual, but we have effective treatment for PTSD. But many of these whiplash injured or traffic injured patients, they don't have real PTSD. It's more like a stress response mechanism. So we have to be very mindful of not calling everything PTSD as well. Yeah.
This one is very simple and interesting as well. What is the most important skill set a clinician should learn in the future? I guess a clinician treating musculoskeletal or chronic pain.
Simple question.
Simple question. Just pick one. Look. I think that I think like skills like manual therapy or acupuncture, they're very easy to learn. You can pick them up very, very easily. I think the capacity to communicate, and by that I mean listen and really get to know your patient and try and align your model and their model in care. I think that's critical, and I think that is a harder fought skill. I think that takes a lot of getting it wrong to get it right. So
yeah, I really agree. I think what's key for me is to create a situation where you tell the patients you have this frame around. Now I will start to learn you a little better, to know you a little better. Then schedule some time for that before you just start to intervene, because intervention too early, that doesn't create any effects. I used to say establish relation before intervention, but the intervention is really to establish the relationship and really learn and understand your patient. So the easy answer is to sit on your hand and listen.
Yeah. And if you take the perspective that from active inference, is that like if we're trying to treat sensory information, that's like normal therapeutics. If trying to treat in some ways or manage and deal with kind of aspects of the person's model and top-down predictions, that means you have to understand their model.
True.
And their model is them.
True.
So you have to
that's
know
a very
them.
clever way of putting it. That's exactly what it is.
You,
the model is them.
You are your model.
Yeah.
You are your model. And so that means get to know them. And that, I say this from a privileged position. I saw a patient the night before I flew out, and my initial consultation was 3 hours long. right?
Mm.
3 hours long. We're on the right road. We're making progress, and it's great. But I couldn't have done it, and I don't think it would have worked as well as 6 30-minute sessions.
Yeah.
But that's and the problem, the challenge we face, and I recognize this in the real world. That's not how clinics are structured. It's not how health services are structured, etc. I completely get that,
Mm.
but that's what was required,
Mm.
or at least I felt.
True.
Do you have more questions here in the room?
Any concluding remarks or questions?
We have no more. But
No.
there were many, but we have selected.
There were
those
very
most
many good
interesting.
questions. I am very sorry. Thank you guys for your kindness of coming and using your time. I think it's time now for us to wrap it up. I am very glad that we had both presenters over for a visit. I am particularly glad that we got Merv over for a visit to help us with the tech stuff. Thanks, Merv. It's a good thing we have good colleagues and friends on the other side of the globe to fly in for IT support. Thanks, Merv. Yeah. No, thank you guys for coming here today for our talk. I really appreciate it. I really appreciate everybody who followed us online in this afternoon session. It will be available on the project's homepage. We will send out links. We will have it will be on the YouTube channel for the project, right?
Yes.
Yes. Sí, as we say in Spanish. One thing that I would like everybody to help us out with is we have a survey going on currently where we are trying to get a feeling or get an overview of the digital behavior of healthy people like yourselves, but also patients. What we're trying to get a little bit more information about is if we seek healthcare information online, what is our strategy to do so? Where do we seek the information? Where do we find it? How do we use it, etc.? It comes in multiple languages. So if you would be so kind to just follow the QR code, you can do it now, or you can do it in the privacy of your home on home. So of course applies for those sitting at home. Go in and fill it out. It would be a tremendous help for us. Also, feel free to follow us on our multiple social media platforms. I must admit, as a grown-up person, TikTok is not one of the platforms I personally am on, but some people are. So feel free to follow us as broadly as you want. On that note, I want to say thank you very much for coming. Thanks to the presenters for being here today. Thanks to everybody at home, and have a good evening. Thank you.